your report. See, this is what. Okay, you'll see whoever's talking. Okay.
Is it recording?
It's recording.
Thank you, Michael. You're welcome.
Okay, good afternoon. Welcome to our weekly public health seminar series. Today we have Dr. Byron Kennedy, the Department of Health Director of New Haven. Dr. Kennedy has obviously a glorious career. He was the County Commissioner of Health for Monroe County, New York, and before that he worked in California, helping the legislature. Dr. Kennedy has MD from Yale, MPH from Yale, and a PhD also from Yale. And he got a job in New Haven. How convenient.
Yale man.
So let's welcome Dr. Kennedy. We all know how busy a health director is, so it is very kind of him to really make time and come here and address our students and faculty. Thank you very much.
Good afternoon, everybody. I am delighted maybe to be here. I'm going to cover maybe a few things, and part of what I'm hoping to do is just give you a sense and a flavor of not only the work that I do in New Haven, but more importantly, an idea of what you typically, encounter, from a local health director's perspective, regardless of what community that you're in. And I think that the best way to sort of highlight that is to really just give you some of the cases, real cases that I've encountered as a local health director. Many of that reflects, my experience in New Haven, but there's a couple of them that actually reflect my experience when I was in upstate New York. So with this first case, we actually had, a student that had actually called, one of our sister agencies, at the county level. And they were complaining about, some liquid metal substance that was actually, underneath their vanity. Initially, when they called, they were actually not, have folks deploy, from an agency to come and investigate it. This student, subsequently ends up recalling, the county, ended up getting in touch with my department this time. And then when our department, was contacted, that actually prompted us to reach out to one of our sister agencies in addition to ourselves in order to investigate what was going on. In this particular case, the student actually told us that there were several things that had happened. And she said that she'd been living in this apartment, roughly over a year, because she started going to school locally. And then she had noticed, that, underneath the vanity, she saw this liquid. She wasn't quite sure what it was, so she ended up reaching out to property management. Property management actually maybe came to this property. They actually ended up, doing a cleaning of the property, told her there was nothing to worry about, and then left on their way. Subsequently, she saw, other sources, of the same contaminant there. When our actually folks arrived on scene, we had some of our other first responders as well, primarily maybe those that are involved in hazmat. So oftentimes that includes, your first responders such as fire department. Our department in the past, had more of a role in hazmat, but in more recent, I guess maybe years, less so. And so we rely more on other agencies, including like our fire department, to be the lead, if you will, for hazmat, types of situations. So in this particular case, given what the story was, and when they actually came in, they actually took some measurements even before they stepped into, the student's apartment. And those ambient measurements actually indicated before they even stepped in that the levels are really high. With this particular student, once they got in, to the apartment, they realized that, okay, there is some contamination. So the first thing that we actually consider in those instances is wanting to make sure that that student is actually put in a safe environment. And so through that, we contacted, the property management. They owned another of other properties locally, so it was easy enough to sort of move her stuff and move her to another one of their properties, and then she could continue going to school. And then from our perspective, as well as some of our other agencies, continue some of the mitigation efforts at that place. Subsequently, the student realized that she had forgotten some of her critical books that she needed to study, so she came back. Incidentally, when she came back, they realized that there was some secondary contamination that she had on her, so that prompted the question for, okay, where's this coming from? So they ended up, going back to her other apartment, testing what was going on there. Turns out she had actually traced or tracked, if you will, some of the contaminant back into the new apartment. So then from that perspective, we wanted to make sure that other places she had been, including school, were also safe. And so with that investigation, when we looked, it turns out she hadn't contaminated any places on campus. So it was just really localized, to her secondary apartment. When we actually ended up testing, her blood levels, those were extremely elevated, and those levels went down the subsequent week. There were some other individuals that we wanted to test as well, including the actual maintenance crew that came to her apartment. Difficult maybe to get a hold of them. One, because they were a contracting agency, and then when we actually did get a hold of them, they refused. And so, from our perspective, we were a little bit constrained in terms of what we could actually do in that situation. But in this particular case, one obvious question was, where did this lead come, or where did this mercury come from? So as we thought about that, she actually did maybe reveal that her father had actually worked at a plant where there was a lot of exposure to metallic mercury. But then we were also thinking, all right, could someone have just broken a thermostat and dumped it down the sink? The level was so high, and there was so much maybe volume that we thought that was probably less likely to be the case. So we couldn't really determine really what the source was. But oftentimes in public health, even if you can't determine exactly what the source is, you can still take mitigation efforts in order to control what's going on, so you don't have subsequent contamination. Second case, we actually had a woman, who was doing some spring cleaning, if you will, in her at her home, and she was actually in the garage. And when she was actually doing the cleaning at that point in time, she noticed, that this raccoon was actually very aggressive in the space, and so she tried to shoo it away, with her broom. The animal ended up leaving, and then that was really the end of it until she realized that, oh my God, she had actually had some blood on her leg. So she presumed that she had been scratched or she had been bitten. That prompted her calling our department. And when we get the call, we reached out with several other folks, including animal control. And one of the reasons why we do that oftentimes is the animal control, if they can, try to identify where that animal is, bring the animal in for testing. If it's a wild animal, oftentimes that involves sacrificing the animal and sending the specimens to the reference laboratory at the state level. And then that was done in this particular case, and it was actually demonstrated that that animal was positive for rabies. And so in rabies, situations, oftentimes, people are concerned about, their dogs, their cats, and I can tell you, for the most part, in much of New York State as well as in Connecticut, those are less likely to be, if you will, the culprit for rabies, as opposed to wild animals, including bats, including raccoons, including foxes. So those are really the animals that you have to be most concerned about. And then even when we actually do have an exposure, maybe to rabies, the protocol maybe that we follow based on CDC guidelines is pretty good, to the extent that, if you follow the protocol, so far there's not been documented cases of rabies transmission because of the protocol that's implemented. In the country, you roughly have about maybe half a dozen cases of rabies that occur nationwide. So if you actually do end up having a rabies case, it is a big deal in any community where that occurs. And as an example of how that exposure might have occurred, sometimes we get a story, oftentimes that an individual, such as a veteran or somebody in the active military was abroad. When they were abroad, they remember that they actually had an encounter with a dog that bit them. They thought nothing of it. And then oftentimes they come maybe to Europe before they come back stateside. And then it's a couple of weeks maybe later that they start developing some vague symptoms. And then when those symptoms go worse, they oftentimes, go to the hospital, they get admitted. And then as you're running certain routine tests and those routine tests are coming back negative, you're sort of scratching your head about what's going on with this person. Sometimes you might actually have a student that goes in there, such as a medical student that does a really detailed medical history that turns out, wow, this person was abroad and they were bit by a dog. Once that information is in your hands, then boom, a light bulb goes off. And then you start thinking about other tests that you actually want to consider, including for rabies. And so that's typically, what we will see, in this country when we actually have actual cases that occur. And again, that's very rare. Generally, when a person actually has an exposure, we think about, in the wound that they were bitten or where they were scratched, infiltrating immunoglobulin in that area, actually into the wound, which can be pretty painful. We would also think about, giving them the rabies vaccine. And we give 4 doses on day 0, 3, 7, and 14. And those are in an intramuscular site, so that you can sort of complete that. Now, it's relatively expensive. So sometimes, when we are going by the criteria, that's pretty strict. We also have, folks that might figure, well, I think I might have been exposed to something, like maybe this dog, and I figure, all right, is the dog, was it acting strange? If I go, well, no, and it's a neighborhood dog that I'm aware of, then in that instance, that won't necessarily be criteria for us. Because for the most part, rabies can only be transmitted, if an animal is symptomatic. So if that animal was actually completely normal at the time that you saw it, then there really is, very limited, way that they could actually transmit rabies. And then oftentimes when we think about the transmission rate, we use like a cushion period when we're thinking about, how to look at the timetable in terms of when their exposure was or what needs to happen during that time. Oftentimes you might have a situation where a family says, well, there was a bat, that was in the house, and it happened to be in the nursery where we actually had a young infant. In a situation like that, where the actual individual that was affected may not necessarily be able to remember to give you a good story, we will just sort of presume that that was a significant exposure, and we'll go all through our protocol in terms of prophylaxis, because you don't want to take a chance. Because, while the protocol that we actually have is pretty good in terms of preventing it, if somebody does, develop, rabies, it's generally universally considered fatal. We've had, a handful of cases where that's not been the case, but that's so rare, so, with regards to, best practices and standards, we consider it fatal, and so for that reason, we take it seriously in terms of what we need to do in those situations. That being said, it is an expensive treatment. It can cost, upwards of $5,000 just on the first day of treatment. And so then that means we do have to use a certain amount of, criteria when we're determining how to go about that. Classic foodborne outbreak, another case. This was interesting, because we ended up having two different parties that were at this one restaurant, hotel restaurant. One was a retirement, or holiday party, and then the other one was a wedding party. And so they actually had certain common foods that were being shared to different parties sitting in different situations in different places of this hotel restaurant. And then folks ended up developing their symptoms, gastrointestinal, including fever, including nausea, roughly within about 12 to 14 hours. And so this particular case, the main culprit was the prime rib of beef. And with the prime rib of beef, the real reason why this was a problem, because when we actually got the first reports, and many of the reports came in from folks that were in the holiday party of the company. Folks were telling us, oh, that the food was really good. However, I started feeling sick. So as we started getting those reports in, we did our investigation. The first thing we do is, we talk to the kitchen staff and we talk to the chef. And when we talk to them, we're getting answers from them that sort of, will determine what our next steps are. In this particular instance, the chef had actually acknowledged that the cook temperature was not as high as it should have been. It was actually at 110, rather than they require 130 degrees for rare roast beef. So as we were getting more information, from both parties, it was striking that in the wedding party, there was less cooperation. And later we ended up finding out the reason why there was less cooperation was because the parents, of the bride, had more or less told everybody not to cooperate with us. And we understand that the reason why was because they didn't want their daughter's wedding being remembered as the wedding that made everybody sick. So it was really difficult to get that information. That being said, because we actually did have a common food source that the chef actually acknowledged was served to both parties, we were able to get samples of that. And we're also able to get, several samples of stools. And so that was able to really maybe link the two together. And in fact, showing like an attack rate of 100% for the prime rib of beef. So this was actually really nice. Oftentimes, when you're doing these outbreaks, it can be like a needle in a haystack. If you're not moving on them quickly, you're not getting the cooperation, you're not getting the information. If, on the other hand, we had not gotten cooperation from, let's say, the restaurant, from the hotel restaurant, a couple tools that we have in our toolkit, we could do like a media blast that basically says, anybody that ate at this hotel restaurant on these days between these times, please call the health department because you might have been exposed to X, Y, and Z. We don't like doing that for obvious reasons. One of them, being that the fact that could actually really damage the company and really damage the business, and that's not our role. Our role is really to protect the public's health. And so to the extent that we can actually do that and get the cooperation of the affected parties, then we don't need to take those extraordinary steps to do that. That can have a devastating and long-lasting impact, on the business. This next case maybe involved, a 2-year-old boy. And with this 2-year-old boy, he had some routine minor, respiratory symptoms going on, including a sore throat, including some ear pains, some nasal discharge, and even a fever. His mother had had, similar respiratory symptoms, previously. And so what ended up happening with this child is, because of the symptoms, they ended up going, to, the ER. When they went to the ER, the child was diagnosed with the ear infection, right? Pretty common diagnosis. The child was prescribed some antibiotics. Upon leaving the ER, the mom, with the boyfriend, they went to the pharmacy, picked up the script, gave the antibiotics, and then that was it. On the other hand, the problem with that, was, later in the day that this kid got sicker despite, starting oral antibiotics. And then to the point where I will tell you this happened during it was actually during the summer. And so with this particular case, the child actually had a younger sibling. The mom brought the two children and herself, over to the boyfriend that was involved. And so the rumor that we heard previously was that the reason why they did that was because the mom did not have air conditioning. And this was a very hot day. I think it was like Memorial Day weekend or something like that. So they ended up going over there. When the child is actually in one of the bedrooms, the mother's coming back, periodically checking. And so at one point you got a kid that's feeling a little bit sick, another one more lethargic, and then at one point unresponsive. At which point, you have the boyfriend initiating CPR. They end up calling 911. The pre-hospital staff may be arriving maybe on the scene. And then en route, as they're on their way to a hospital, and I will say this is the second hospital, the child is actually pronounced before arrival. Pronounced as having died. And so when that happened, devastating, for anybody to die, but particularly a child, and particularly a child that was, for all practical purposes, in the last 24 hours, perfectly healthy. And then all of a sudden it went downhill and completely crashed. And so then as we were looking at the information when this report, came to us, the contact information that we actually called, that we presumed was the mom, actually turned out to be a foster parent. So we're like, oh, foster child. So as we're talking, to this individual, who's an older woman, she expressed some of her concerns about the family situation because she had been a foster parent for this child for a number of years, and in fact had taken the steps of wanting to adopt the child at some point, but was unsuccessful in that attempt. And so she expressed me the concern about what might have gone on because she noted that there was like a bruise on the child's head. So when we got that information, made us a little more concerned and a little more thinking, what can we do here to kind of get answers for this family. So with this particular child, we ended up calling the medical examiner's office that we work very closely with so they could do additional tests. Oftentimes, if an individual does not go to the hospital, you're not, for whatever reason, you're not going to have the luxury of being able to get various lab tests, whether that's blood, whether that's urine, etc. From the medical examiner's maybe perspective, they will oftentimes collect specimens on any body fluid that they can get, particularly in this case, where it's like, okay, what's going on? So we need answers. We separately requested that specimens be collected and be sent to the state reference lab so we could actually test them among other things for meningococcal disease, because we were like a little uncertain about what was going on. And so then when this happened, I will say this actually occurred during the week, and then during the week we thought we would get the results for the following week. We actually got the results within 24 hours from the PCR test that actually confirmed that this was meningococcal disease. And so there's relatively few things that are public health emergencies that we have to address. That's one of them, because we have to take further steps to make sure that the folks that were exposed, including the household members, first responders, are appropriately prophylaxed with medications to prevent their chance of actually acquiring meningococcal disease from bacterial meningitis, which can be deadly. So we ended up doing that in this case. And then as we're thinking about, these bruises that this child had, what was explained to us later on was that this kid, at the home, there's, a dog that the kid would sit on. And so the presumption is the child might have fallen off, the dog and hit his head. But we didn't find any other evidence that warranted, following up on that particular piece. This case, tattoo skin infection. So this involved a 20-year-old male, who had had many tattoos in his past history. And then at this one particular time, he goes to this one set, tattoo parlor, to this one artist, that has a really good reputation for doing great results with different shadings. And the different shadings allow you to get more realistic, images, of the tattoo itself. And so that particular impression of the tattoo, fairly maybe highly sought after. And so with this particular individual, on this most recent tattoo that he received, he ended up developing a rash, in the said area. and initially didn't think there was not that much big deal to it until the rash didn't go away. So ultimately that led him to go to his primary care provider. Primary care provider, he was thinking, all right, probably a dermatitis, some type of local reaction, so I'm going to prescribe some steroids, which he did. The guy took the steroids, still didn't get better, goes back to his primary refers him to a dermatologist. Dermatologist, in this particular case, decided to do a biopsy. But importantly, the dermatologist, as he questioned this individual shared with him that there were other folks at the same tattoo parlor who had similar reactions happen after having received this tattoo from this one particular artist at this one particular facility. So that's what the dermatologist was sharing to us, because actually that's how the report came in. It actually came from the dermatologist reaching out to our health department. So when we got that information, we reached out to the individual. We confirmed the information that the dermatologist shared with us. And then the next thing was we wanted to actually get specimen selection so we could actually send those out to the state reference lab for testing. Now, in this particular case, we did like a quick literature search, about, reactions that don't go away with steroids. And there was already in the evidence, a case series, the largest case series maybe in Paris, that actually showed you had contaminated, ink that led to microbacterial reactions, in that skin that was tattooed. And so we suspected we had something similar here. And so not only with this individual, but with the other folks that were there. So we had to have the guy come back in and be re-biopsied, then have the specimen sent, to the state reference lab for testing. And then we also needed to identify those other individuals. At this point, we heard about a dozen. So when we went back, to the actual facility with our environmental inspectors, they tested the water samples, which were fine. They actually collected the ink that was still used on this individual that was open, but we also collected the unopened bottles as well. As we talked to this tattoo artist, he said that he went to a trade show in Arizona and had bought these pre-mixed, inks together. And so that's what allowed him to achieve, if you will, these results that were realistic in terms of their impression on the tattoo. Then as we started, connecting the dots maybe together, it became clear, that we were dealing with contaminated ink that was contaminated before it was opened. And we were able to confirm that through PCR testing in the state reference lab. And the fact that it crossed maybe state lines and came from another source that actually, attracted the attention of the CDC as well as the FDA. And in the Arizona, tattoo parlor, where the ink came from, the tattoo artist himself said, I don't really make the ink, I just allow them to use my name. And so they ended up also sharing that, the actual ink, manufacturer is this other facility, in Arizona. When the FDA actually went out to this facility, the facility was somebody's kitchen. And they would take orders, online and elsewise, and then they would just send out the orders, once folks paid their check. So at this point, that, a manufacturer was claiming that our local artist was responsible for the contamination, but we knew that wasn't true because we had tested the water. We actually interviewed maybe individuals as well, and they said, no, it went directly from an open container to a sterile container to my skin. No mixing, because that was the whole idea of actually giving the pre-mixed ink, right? So that was good that we did that piece because it sort of protected the liability from our artist, and then and again, from the business from being appropriately shut down. The CDC also did like a national recall of this particular product. And then through that work, that actually ended up identifying other clusters around the country, that had occurred. So we ended up, writing this up. So that had a good result, to the extent, that we were able to sort of put dots together that otherwise would be very difficult. But what made that actually feasible was the fact that we had multiple folks that were helping out, including we had interns, we had residents, we had, other fellows and other support that were helping with the work. Because we have a normal work that we have to do. So we have something big like this, or that's expanding. It's nice that we actually have other folks that are working in our department at the time. This next case, was an elderly man who had, fevers, chills, night sweats, coughing, some unintentional weight loss. Ended up going to the hospital. With that, presentation, the guy was initially diagnosed with pneumonia, and then was presumptively treated for that, but was not getting better on the pneumonia treatment. So that led them, to do additional tests, which ultimately led to the diagnosis of pulmonary tuberculosis. This particular individual, had actually been an immigrant to our community 20 years prior. And when we were actually connecting the dots here, we recognized, that while a positive PP test was already in the record 20 years ago, there was no evidence that either a follow-up chest X-ray had been done, which you would do if you have a positive screening test. There was also no evidence that this person had been on any type of preventive therapy, or presumably latent TB. So when this guy was diagnosed with pulmonary TB, he was put on standard, 2 weeks treatment of white. And then for the symptoms, those actually improved. And then when we think about, criteria for when somebody's non-infectious, not only symptoms, but also it's the fact that we have some laboratory confirmation of some sort, because as the health director, we're responsible for whether or not a person is going to go out to the community. So one of the things we consider is whether the person is infectious or non-infectious. They're generally considered non-infectious if the symptoms are fine or have improved. They've been on standard, treatment for like at least 2 weeks, and then we have some laboratory confirmation. Either the smears have been negative times 3, at least 8 hours apart, including one that's been done early in the morning. Or, they've done like, a gene expert that's done some PCR tests that it really gives us confirmation. Or we have liquid cultures that are no go to date, times 4 weeks. So we need one of those 3. And then if we have that, then we know that they're non-infectious, and at that point, we're okay with them going home. If we don't have the laboratory confirmation, then we have to weigh other things. And so other things that we have to consider is the follow-up plan for the TB program in our department. Because being able to establish, directly observed therapy, so they can continue their medications, making sure that there's nobody else in the household, that is really at risk, for acquiring infection, which includes children less than 5, as well as folks who are immunocompromised. And then key, we want to make sure that this person is able to remain on home isolation, until they're not infectious. If the person's like, all right, I'm going to go home, but then once you leave, they're going to go to work at a daycare, then that would be a problem for us. The other case we had, and this was within the last year, teenage boy came in with fatigue, malaise, a non-itchy reddish rash on his palms. And in this case, he didn't come in alone. He was brought in by his grandmother. So this was actually maybe nice for our clinic, because oftentimes we think about folks who either coming self-referring themselves or they're being referred by a friend or by an agency. We don't think about grandmothers actually bringing maybe their children into an STI clinic. So this was actually maybe nice, because it actually demonstrated maybe to us some of the credibility and the reputation that our services and our staff have in the community, such that folks maybe feel comfortable bringing in, like I said, folks maybe that they know that they love as part of their family. So with this guy, that presentation, we think about rash on the palms. There's a short list of what can lead to that. And so one of the things is syphilis. And in this case, we in our lab, or in our clinic, we have a rapid test that allows us to do a test right there in the spot, including syphilis, so that was positive. We also do rapid HIV testing. That was positive as well. And so then we actually talked with some of our state colleagues that are embedded in our clinic, so they're able to determine, all right, they're positive syphilis, positive HIV, but maybe they've been positive for like a long time. So they will actually check their state data, and then they actually will cross-check it with some other states, just to confirm that, no, this is in fact a new diagnosis for both of those. And then a couple things that were considerations, for this particular individual. Young MSM had multiple partners. I already mentioned this was a teenager, that was like 15. The sexual partners were all adults, or at least that's what we're being told, or had involved, like maybe adults, I guess maybe in the past. This was an individual, who actually went to school in our community, but his social network was in one of the suburbs, because he didn't really feel that at the particular school where he was at, that he had enough support and social networking like right there. So if you will, feeling disconnected. There were access maybe to care barriers in terms of like insurance, out-of-pocket cost. There were household stressors. So this particular individual was staying with his father. His mother had previously died. He had been in foster care for a certain amount of time. And then the mother figure, which was his dad's sister, his aunt, she had recently died as well. So having, those types of stresses within life made it really difficult, in addition to being at a school where you don't feel you can connect with anybody. So you're sort of dealing with those issues, in terms of those social dynamic and familial issues that impact, if you will, some of the public health matters. There's well-established link between syphilis and HIV. Syphilis increases the risk for HIV. HIV increases the risk, for syphilis. This individual was treated, appropriately, in our clinic. And then we actually sent out for other labs, which we can't do immediately. And those just give us confirmatory results about not only the diagnosis that we established with the rapid test, but we also test for other things. Importantly, we want to give this person, which we did, link to care so they can actually initiate antiretroviral therapy for the HIV. More recently, back in August, over a 48-hour span, on our central downtown green in New Haven, we had over 100 overdoses that occurred. And thankfully, we were fortunate that, no one died. In contrast to other similar overdoses that occurred in Chicago earlier this year, New York, and Philadelphia. In this particular case, the testing results, demonstrated that it was actually K2, a synthetic cannabinoid. Narcan was administered. Now the thing is, Narcan really doesn't have an impact, on synthetic cannabinoid, but you don't know that when you are arriving on the scene. When you arrive on the scene and somebody's unresponsive and they've had a drug overdose, you're going to actually have to use Narcan until proven otherwise. And oftentimes you're going to use more than one dose because, think about fentanyl. Fentanyl, is oftentimes, diagnosed empirically just by the fact that it's an opioid, but it takes more than one standard dose of Narcan to bring somebody back. So in this particular instance, we're using multiple doses of Narcan on the green in the field, and they're not getting better. But then in this case, the effects of K2 usually are short-lived. They usually wear off and a person is back to clinical baseline in about 20 to 30 minutes. And in fact, folks that were transported to our hospital and then discharged because they had no reason maybe to keep them because they were clinically stable, these folks came back to the green to actually have another high, to have another episode. In fact, we have folks that did that 4 to 5 times. So that includes the 100 doses. I would also say that the majority of the individuals that were having the overdoses, they were not from our community. They had actually come in. And some of that is because we have, really good resources and services, in the city of New Haven for treatment centers. And so that draws, folks from some of the surrounding areas to come in, among other things. So we're fortunate in terms of not having any deaths, but just with the huge load of the huge capacity and all the work that goes into this, and then trying to figure out, how do we address this? We had early at the beginning of the year, we actually had a K2 overdose that was a much smaller number, about 20-some of cases. And the K2 involved in that instance, was unrelated to this K2, although the K2 in this most recent August event was more related to what had happened previously in Philadelphia. So that, if you will, it suggests, certain chains of supply. And as we talked with different folks on the green through our law enforcement, they were able to identify that, much of this, K2 had been given away for free. Not sold, but given. So, we are certainly with many other communities maybe around the country during this epidemic of drug overdose, whether it's K2 or whether we're talking opioids. So to think about what to do about it, obviously I think there's a lot of consensus on there needs to be more services for mental and behavioral services, including addiction. Having recovery coaches, and recovery coaches are a little bit different, than the addiction services because by definition, those oftentimes are peers. Who had, more struggles in the beginning, but now they've been able to be clean for a certain period of time, so then they can actually work more closely with an individual who's going through different steps. Also, with a recovery coach, you're actually making decisions about what that person is ready for at this point in time, rather than telling them, here's the standard that you need to follow. You're really asking them, okay, so where are you, what would you like to start with? So it's really, if you will, patient-centered. Having Narcan availability. Narcan availability is not just having actually a Narcan, but when you think about how you distribute it, now in some cases, some communities, you distribute it mainly through writing a script. That certainly is more limiting, as opposed to just being able to hand it out. On this event, we actually depleted a large portions of our Narcan because we were using it, on the scene. So we actually worked, closely, with the state health commissioner that actually provided Narcan later that day to help replenish what we had utilized throughout, that early morning. Medication, assisted treatment availability. There's a limited number of sites, around the country, and each of those sites, they have a maximum capacity of the number of unique patients they can follow in any 12-month period. Then you're actually thinking about, how they actually deliver, the MAT according to best practices. Stigma is certainly maybe there. And we actually had a conference, actually last year at Yale Law School, and you actually had a panel of mothers, each of them who had lost maybe a child, more or less in their teens and in their 20s, and talk about, the stigma that was associated with their children. And I think there's been a lot of progress compared to, the drug addiction and the drug overdose of that in the past, but certainly have a long ways to go to kind of address that. Other things we want to think about is, acute versus chronic, minor versus major pain. There's a lot of guidelines right now on chronic pain, but relatively few for acute pain. And in fact, so few, that you actually have the CDC director right now currently having the CDC charged with coming up with acute pain guidelines, just to give folks better guidance. You have some that may be reflected at certain hospitals and certain clinics, but from a broader perspective, less. That being said, the literature maybe suggests that when you're talking about acute minor pain, that you should first think about non-pharmacologic approaches, which include whether that's heat, whether that's rest, whether that's ice. And then if you're thinking about pharmacology, the typical stuff, Tylenol, Motrin, using those in combination has been shown in many studies to be as effective as opioids. And if you have to add something else, perhaps you think about a muscle relaxant or some other non-opioid alternative. Other thing is having data reporting. In the state of Connecticut, like most states, fatal overdoses are reportable, but non-fatal are not. And so we're only thinking about, those who actually died. We missed an opportunity for all those that have been brought back through Narcan or through other acute, management. And so what can we actually glean, from those families and from those individuals and from those communities? And then also, prescription monitoring programs, most states have those. And the idea is that before you prescribe something that's controlled substance, you check that database to make sure that somebody doesn't have something else on board. So defining public health, there's many definitions out there. I kind of like this definition from Winslow because it highlights the community efforts, that is critical. As a physician, excuse myself, I would no more, want to impose a treatment on the patient, even if I thought this is a certain treatment that you should have. I think we should use that same lens when we're talking about community initiatives, community programs, and efforts. We don't want to impose that on the community. We actually really want to have this to be a bilateral commitment and partnership. Institute of Medicine, has established core functions of essential services back in the 80s. And essentially this roughly represents what local health departments around the country, should be focusing their efforts and their time on. That being said, obviously we have a lot of demands on us. We have a lot of mandates, but we have limited funding, we have limited staff capacity. And so when you have less resources for what you need to do, you have to prioritize your work. And so in our case, it's helpful that, we have national priorities. Oftentimes those get articulated and get tweaked at the state and then local level. But when you think about the Healthy People 2020, which is, if you will, the foundation for most of our prioritization that we do locally, one of the more recent versions has focused on disparities, eliminating those and addressing those. Then also thinking about the social determinants of health and impacting those as well. And then when we're thinking about where are you going to be more strategic with your efforts and with your limited resources, if you think about things at the bottom of this pyramid, those are likely to go much further and be more cost efficient and have more impact on populations than if you think about those at the top of the curve. Not that the things at the top of the curve are not helpful, they are, but at the end of the day, they have less population impacts, than those towards the bottom. And then of course, not everybody's starting from a level playing field. With the social determinants of health, it acknowledges, that there are folks, there are families, there are communities that are have more challenges, more barriers. Similar to this, individual pushing, this boulder up. If we told them, well, you're just deconditioned, you're just tired, or you're lazy, or you just need some better shoes, and then you can actually get up the hill faster and push this across the finish line, as opposed to, actually, why don't we just think about lowering that incline and making it level? And then this person, has more capacity to sort of use their efforts in a more intelligent, more efficient way. And of course, this brings up, again, the general theme of just equity. Equity is not equality. Equality is really the notion of giving everybody the same thing. Equity focuses more on what's fair. And so what this diagram maybe highlights is that when you're talking about like maybe what's fair, is not just giving everybody the same level box because folks are at different starting points, but it's actually giving folks, a certain level of assistance, but they still have to put some effort. So it's not like we're saying that, okay, with this diagram, all right, somebody has to go up and pick the apples for you and give them to you. It's like, no, we still want folks, to take some responsibility, personal accountability for their own health, for their own communities. But we also want to make sure that we actually have things that address some of the structural barriers as well. And so with federal government, there's different, branches, executive and legislative branch, and in my case, as a public health maybe official, I deal with, the executive, legislative, and judicial branches maybe of government with a certain amount of regularity. At the executive level, that's where we have the appointments, of officials like myself. We also come up with our budget proposals. but it's the legislative, branch that actually does the confirmations, they approve budgets, and then they help with regulation. And then we deal with the judicial branch oftentimes through enforcement. I'm in the public sector, and I realize that there are other sectors that we should be collaborating with in order to have an overall better outcome for the populations, for the community. As the public sector, oftentimes maybe like to think about us being, as an example, like a cruise ship. We have a huge impact on a large number of people, but it's very difficult to stop and start, very difficult to change direction. But when we do, it has a huge impact on a large number of folks, whether you're thinking about that's the crew and those are the passengers that are on there. And that's also bureaucracy that slows things down. So we are probably the most potentially impactful just because of the sheer size and sheer scale. On the other hand, we're not the most efficient. So when we actually think about cost efficiency, I think we sort of have to, give a bow, if you will, to the private sector, the for-profit sector, because they focus on cost efficiency, because if they don't, they're not going to exist all that long. So in many cases, they sort of have to think about, their bottom line. And so as an example of that, it might be that, all right, in this health setting, we want to focus on avoiding adverse events because we don't want to get sued. And if we get sued too many times, then it'll shut us down because we won't have money for anything else. So that will actually get you some good outcomes, but that's not the most ideal pathway. Then if you think about the nonprofit sector, it's very different. They actually are driven by their mission statements. So what they live, what they breathe, what they focus on is reflected in that, that mission. And so they align all of their resources and their energy towards that mission. So oftentimes, they are probably the most efficient from a health outcomes basis than either the private sector and us. But the problem with both the private, and the nonprofit sector is scalability. Can those be scaled up, where they represent the entire population, be that a city, a county, or a state, let alone the country? It may or may not be. So I think each of the sectors actually contributes to something very unique, for the overall population health perspective that we need to work together. And these are just some of the many collaborations as a public health official that I'm engaged with. New Haven Health Department, Connecticut State Health Department, healthcare providers in the community, local foundations that provide, if you will, resources or funding, the Chamber of Commerce, which represents our businesses working together, since most folks have insurance through their employer. And then you have community-based and faith-based organizations and many others. For our particular health department, this is our mission and our vision statement, and not entirely different from many others, that you actually find around the country. And then with regards to what we do, this represents our administrative, maybe arms and branches of our agency. And I think I've talked maybe more importantly about what we do with the cases that I've mentioned already. And this is just, where we're at in New Haven, proximal to Long Wharf. Not surprisingly, our city, we have more diversity. We have both on our ethnic and racial basis compared to the county, compared to the state overall. The folks maybe in the city, tend to have a lower educational maybe attainment. We have more acculturation, so again, that adds maybe to the diversity that you see in the city compared to the county and state overall. And then when you think about, the number of businesses that are Black-owned, because the city is such a high proportion African-American and Latino. That's one of the reasons why you have more of that, from a business perspective being localized compared to the county and the state, but certainly not at the levels, as reflected in the population. But of course, not surprising, I guess maybe again, if you live in the city, more likely to be impoverished, regardless of how you define it. And then folks that are in the city, like many others, are more likely to be renters rather than homeowners. And the homeownership obviously has implications for the collection of wealth and the accumulation of wealth over generations. And while the data is dated, and we're updating that like right now as we speak, the relative ranking of the different conditions is approximately the same. We were fortunate in terms of having neighborhood level, data, so we can actually look at different neighborhoods. And like many communities, if you look at a more granular level, you're going to find more disparities that become revealed. And that's certainly true maybe in the case of New Haven, where you actually have large employers like Yale University, Yale Hospital System, and then, other big, entities that are there. And it's just from us all pretty much telling the same picture. And now, New Haven oftentimes, it has a reputation of being quote-unquote unsafe in the neighborhood. And yet, when you actually look at the surveys, we've seen improvement in terms of how folks feel when they walk walk in the neighborhoods, in their neighborhood. Plus, when you actually look at crime statistics, you sort of see that, yeah, once upon a time, the crime statistics for New Haven were, out the roof. I'm now happy to sort of say that, with the community policing program we've adopted for law enforcement, we are now considered one of the safest, urban metros, maybe in all of the state of Connecticut. And in fact, looking at the change that we've actually had, maybe in the country. In fact, we've had, folks, from other states, including New York City, and the others from other countries who come to look at how we do community policing, because the rates that we actually have and the drop is staggering compared to what's going on in other communities still. And then, when you're thinking about other metrics, it's nice to think about years of potential life lost, because on the one hand, everybody dies, but people should not be dying prematurely. And so if you assume that people should at least live, until age 75, if they die before then those were the years maybe that they have lost, prematurely on average. And so both Harford County, New Haven County, where I'm at, and Fairfield County, those have actually improved, in the last 10 years. And this kind of shows, if you will, that in comparison to a couple of counties, in New York, as well as some other ones. I think Prince George County in Maryland has the greatest amount of reduction in the 10-year period, maybe in the country. And then you look at, some of the ones that have had, Pinellas County, which has had the worst. They actually got worse during that 10-year period. And so we're thinking about contributors to premature death. It's not about what providers write as a script. It's not about clinical care. It's really about those behavioral patterns. And that's reflected here. Again, old data, but, accurate with regards to the relative ranking and the contribution. While we can talk about the diagnosis that somebody has, it's more relevant for us to talk about, the actual behaviors and the lifestyle, tobacco being number one, not a surprise for anybody here. And these are the, if you will, the public health, the top achievements, in the 20th century. And so again, it's not about, writing scripts. It's not about, something, really magical or complicated, but just basic fundamental public health, which has had huge dividends and impacts, across not only this country, but across the globe. And so lastly, we want to talk about some of our initiatives that we've done. We've actually had a tobacco-free initiative, where we put more restrictions on smoking, including outdoors, in public spaces. We've launched, an asthma summer camp, in New Haven. This is like our third summer that we just had, and mainly because, in New Haven, we have some of the highest hospitalization rates for asthma, in the state, and in fact, even in this region of the country. The rate being about 75 per 10,000 compared to the rest of the state, which is 14. So huge. And it's not really clear what the reason is. They say, oh, it's about poverty. I said, well, it'd be hard to sort of say that we're more impoverished than Hartford or Bridgeport, the other big cities, within the state. And they don't have nearly maybe the rates of hospitalization that we actually have. So one of the things, again, with public health that I love, even though you don't necessarily know the answer, it doesn't mean you can't take action. And so part of our action is the summer camps. And so what do we do in the summer camp? One, we provide a full-time nurse for the entire, if you will, summertime. And during that time, we want them to have fun. That's the most important. But it's also important because these children can actually see that there is somebody else like them who has asthma. There's somebody else like them who has to use and needs an inhaler, rather than the uncool kid. It's like, oh my God, I'm just going to hide this because I don't want to stick out. So we think that that's really important about normalizing, if you will, their condition, and then actually having, if you will, that support from others that are their peers, because we know that, peer has a huge impact on behavior. Working with some of our community-based organizations, we've done some efforts, and we have more to go in terms of food recovery program, particularly, ones that target, restaurants, because you have a lot of food insecurity in the New Haven, like you have in many places. And then in addition to that, you also have a lot of waste of food, so wanting to sort of, realign, if you will, those purposes so that they're getting to where folks need them. And even if they can't be consumed, then having alternative uses for those, whether that's composting or whether that's just reducing your overall burden and your cost of actually having the garbage. Did an initiative, in a senior center that had those that were at risk, including many individuals who had diabetes or were at risk of diabetes. And the idea there was to come on site and to provide services to them. And so we did this in collaboration with our Fairly Qualified Health Center. And then having a peer program so that seniors could be trained to be peer supports to one another. If it was something like, helping them to navigate an appointment with a provider. Lastly, I'm going to talk about our Getting to Zero. That's the most recent initiative that we've been involved in. And by Getting to Zero, there's been other places that have focused on this, including Massachusetts, including New York, including California. What is that? Getting to zero HIV deaths, zero HIV infections, zero HIV stigma. This effort has focused on the 5 big cities, including ours, and then 3 subgroups in particular, which are the subgroups that have been projected to have the highest risk of HIV acquiring as well as transmission over the next 20 years. So MSM of color, Black and African American women, and transgender women. So in summary, I hope we've been able to sort of maybe share, that public health, we don't do this alone, nor do we want to. If we're actually going to be successful, if we're actually going to be impactful, we really have to do it in partnership with others in the community. While we have the mandate, we need the help of others to do this. And that includes, those that are providers, that includes schools, that includes folks that are doing research, et cetera. And we also want to focus on the disparities because we know that everything is not evenly distributed. And if we are going to focus on those disparities, we actually have to think upstream rather than just thinking about, putting band-aids on current conditions. That's our health department. We're right across from the train station, so if you do take the train, you stop in New Haven, we're not that far away until where our office is located. So. Questions? Nice job. Yes.
Okay, thank you for your presentation. I think one thing I noticed in most of the slides was that most of the health challenges follows around the poor, Black, and Hispanic.
Mm-hmm.
Yes. So maybe you could educate me on what programs you're carrying out to address this particular group of people, one, and what is health insurance coverage within the same set of people.
I'll start with the second question. Connecticut actually has, fairly high rates of health insurance maybe coverage compared to most other states. That being said, access is more about insurance. It's, you can have access issues even if a person has insurance if there are out-of-pocket costs. There can be access issues if a person says, I have transportation issues because I don't have the extra money, or the time to take off maybe from work in order to catch multiple buses to go to this particular location to get certain services. And so I think to that extent, there are still maybe gaps not only in my New Haven and Connecticut, but I think nationwide. Some of our programs that we have, we try to make those, culturally maybe appropriate by trying to have folks from the community who work in our department as community health workers. We also try to be sensitive in terms of how we deliver our services and where we deliver them, including going out into the community or partnering with, other agencies at events and at locations where folks in the community are coming to anyway, so that it's less of an extraordinary just maybe effort for them to come for something that's convenient for us, but not convenient for them. As an example of that, our building that I showed you, we are co-located in that building with the Board of Education. So because we're co-located with the Board of Education, many families come to that location already because they're enrolling their children for school for the fall. So as they're doing that, we also have a clinic on that first floor so that if that child needs a vaccination or if they need a school physical, we can actually make sure that they actually get that. So that makes it a little more convenient rather than have to take an extraordinary effort since they were coming here just for a Board of Ed issue to receive services that we have. Other question? Yes.
In regards to the population, is there a high presence of migrant workers in your heaven that you know of?
We do.
Or seasonal workers?
Certainly, I guess maybe within the Connecticut, I guess maybe region, to a lesser extent in New Haven proper. But certainly within the state and within the region. And that, as you can imagine, is seasonal, based upon, whether that's, for apple season or whether that's for whatever.
And how, if there are any pockets of those populations who also get uninsured, are there any safety net programs or initiatives that the department has reported for the healthcare needs of these individuals?
So, a couple things that we have in the community. We have our federally qualified health centers, and we actually have two in particular. And as a federally qualified health center, they are mandated not to turn anybody away. And they provide primary medical, primary dental, and then some, mental health services, some crucial mental health services. And then they also, while they may charge a sliding scale fee, they can't turn folks away. And then in some cases, like our one federally qualified health center, to your point, about migrant workers, they have more, if you will, outreach programs specifically at that particular health center with the migrant community, throughout the year, and then the surrounding regions. In our clinic, the services that we provide, we don't turn anybody away. And under the Affordable Care Act, oftentimes you had local health departments, that were prohibited initially from billing. Now they're able to bill. In fact, New York State and many other states have actually changed laws in order to allow that to happen. One of the things we are planning to launch, this fall is actually the integrated public health and urgent care clinic. As a physician who does, urgent care living work, I can tell you that most urgent care centers are not located in the inner city. They're located in the suburbs. Most urgent care centers do not accept straight Medicaid. At best, they accept, a managed care Medicaid. And so that creates, if you will, barriers. Although in the state of Connecticut, they do accept Medicaid, but again, many of them are still located outside of the inner cities. So when families actually have acute complaints that occur, like nobody plans on having their child roll their ankle playing soccer. Nobody plans to have their child have an ear infection or an earache or sore throat. When that happens and you can't wait for an appointment several weeks out, at least, what are you going to do? If you need to be seen, you're probably going to call 911 and you're going to go to the ER because you can actually get the care that you need for yourself or for your loved one. And yet in the suburbs, same thing there, but people just have more options. If that child has asthma and they need a nebulizing treatment, and after that neb treatment they feel better, they won't have to go to the hospital. Yes, that's great. That saved the hospitalization. And the family's breathing a little more readily, but you don't have that same access, again, in the inner cities. So that's one of the things that we're trying to address by actually having, to my knowledge, first in the nation, that type of integrated service.
I'm an immigrant resident, great. Thank you for coming.
Thank you.
I'm wondering, back in August when there was all those cases of K2 overdoses, I'm curious, as an department, what was your response like? Like, how did that work from, an administrative thing into actually getting out there and, next step, taking that day over the next week?
Our main role was, if you will, working, our lead agency was, EMS, Emergency Management Services, Rick Fontana, who is amazing. He was the city's lead, gets for that effort. And then under him, you sort of coordinate, with our fire chief and also with our pre-hospital staff, as well as some of the other communities. One of the things, in that first, 10 hours, we realized like, oh my God, we're not going to have any Narcan. So our role was, because we had actually provided Narcan 2 summers ago when you remember we had the overdoses then, and we had 4 deaths. We were able to sort of replenish the supply because our first responders had run out from resources that we had received from the State Department of Public Health. In this particular instance, this August, we had to do the same thing because while, K2 is not an opioid, you still have to use maybe Narcan on an individual, maybe patient, just in case there was contamination or they had something else on board. And so being able to coordinate, that piece. Some of the discussion that we've had, subsequent to that, about, how to address, if you will, the overall issue, not only about opioids, but just, drug overdoses in general and addiction, more broadly speaking. How do we get, some of that information and have some of the partners? Locally, one of the organizations, that many folks from the community will come from the outside to receive services from is like the App Foundation. And so that has been controversial over time with regards to the folks in the community, who think that, well, once upon a time, that particular agency was less busy than it is like right now. And when you actually have folks that not only from New Haven, but importantly from outside the community that are coming there, there's some concerns, from community residents about how to address, if you will, what's going there that might, if you will, exacerbate what's already going on.
Just to follow up to that question, given that I think last year President Trump announced that the opioid crisis is a national emergency, how is that affected your budgeting as far as federal funds?
We did receive, some grant support, with, I think a total of 5, local jurisdictions from the State Health Department. And with the resources that we received, as well as some others, part of that has been used, because it was a small pot of money. I think it's about, $30,000 over a couple of years. So, limited in terms of what you can actually do with those types of resources. And so ours is focused mainly on, if you will, education of providers and training, just to help the folks that are really boots on the ground that are actually seeing, clients, for not only, drug overdose treatment, but also for addiction services and more broadly speaking, for behavioral health. So providing training for them and then coordinating, if you will, that work. Because in some cases, Many folks may not necessarily know about some of the services that particular agency X might offer, or another agency might not be aware of the other services that are complementary to what they have themselves. I know in our own, I guess maybe department, we try to remain up to date about what other services are provided by other agencies, just so we can actually refer patients appropriately. Similarly, we want them to appropriately maybe refer to us, for services that it might be better for us to handle, since we are located, if you will, close to the heart of downtown.
How would the private, because you mentioned private, nonprofit, and public, how would the private sector work with this? So in the sense of would it be more like an agency in the sense that, say if there were, for example, about the hotel, if there was an outbreak of the roast beef, there was a lot of complaints about the roast beef at the hotel, would they hire the agency to go there and investigate, or how would it work?
I'm not sure if I understand your question.
I may have got confused because you said you gave the motorboat example and then the cruise. So I was assuming there's a private sector to this and there's a public sector to this.
Well, I was thinking, as one example, thinking about healthcare services, from a private maybe perspective, as opposed to I have a clinic that's a nonprofit, and so we're a community-based organization, or I'm a public clinic that's offering service. And again, just using the example of healthcare services, as the overarching, theme to sort of contrast those different sectors and what they bring to the table.
Oh, yeah, okay, I got confused by that.
Okay.
Yeah. I particularly like the initiatives that you have going, especially the asthma camp. I grew up with asthma, so I know the feeling of not wanting to show your asthma pump and then being around people who have asthma. You know what I mean? Can you understand what I'm saying with that? So I really particularly like that initiative. But my question is, how many people work for the health department?
We have about,
and more importantly, are you hiring?
Yeah, we have about 100 staff, working for us. And that includes, over 40 nurses that work in the schools. Our capacity has gone down over time. In some other conditions, although we've gone up in our nursing cadre, mainly because, our legislative body, our Board of Elders, has been, very thankful to them for giving us more resources to increase that total number. We cover, 53 schools with 42 nurses. The number of nurses we used to have, at my arrival was 30. So the fact that we've actually gone up, to about, a dozen more, we're still not on average one nurse per school, which is what you find in some of the other big cities, maybe throughout the state, including Hartford and Bridgeport. So we're far away from that. And then in terms of positions that we're hiring for, right now, we just have some vacancies, not only for nurses, there's always a certain amount of turnover there, but also for some of our sanitarians. I would like to expand some of our divisions that we have right now, including our epidemiology division, because I think that is, if you will, that's the scientific backbone of the department. And we hired one epidemiologist, less than a year ago, who was a great, maybe addition, I guess, maybe to our department, but he's just one individual, and so I'm trying to, do what I can to ensure that he's not overwhelmed. Could we easily maybe utilize another, another epidemiologist, even if it was a junior? Absolutely. With this in Connecticut, you have, in contrast to when I was here in New York, they have what they call general and special fund positions. When it's a general fund position, is coming out of the general fund line, of the taxpayer base. And then we have special funds, which is anything besides that. That special fund can be grants. That special fund, can be a donation from a foundation. That special fund can be billing revenue from our clinic over the services that we're billing for. Anything, besides that. With the special fund, you're able to have more freedom about who you can hire when you can hire. In contrast, when I was in upstate New York, you only have general fund employees. And so when you have general fund employees, when you do receive a grant, the grant will offset what the county would pay for a general fund position during the time that you actually have the grant. When the grant goes away, then the county is back on the hook for paying the full salary. And so because of that, I'll just give you an example. If I were, when I was in my former New York, if I said, you know what, I just got a $10 million grant per year from the CDC, guaranteed for the next 20 years. My county administration was like, that's nice, Dr. Kennedy, but we're not going to allow you to add any more additional positions. Why? Because the legacy cost. So if I have $10 million grant per year for 20 years, I can pay a whole bunch of staff. At the end of 20 years, they're now going to say, I'm going to retire. That retirement comes out of what? Not the grant money, but out of the county coffers. And so I think that the county, from Earth's perspective, they want to control those legacy costs, because in the end, not only that is a huge, if you will, maybe expenditure, for local governments and state governments and every employer these days. And so for that reason, they wouldn't allow you to increase your overall headcount in your agency, regardless of what the reason was.
You can shift some of that money?
When you have the grant, but you're not going to be able to increase the overall headcount. So if I, in Rochester, Monroe, I had about 300 staff.
Mm-hmm.
So the 300 staff, again, if I get magical money coming down, they're not going to allow me to add 100. They're not even going to allow me to add 10. Because when that money goes away, we're going to be stuck with the cost of those 10 employees you added 20 years ago, because now we're paying for their insurance, we're paying for their retirement, we're paying for their health benefits, and they're dependent. So in Connecticut, it's cleaner, because yes and no. In the state of maybe Connecticut, when we receive maybe a grant, it does not offset general fund employees. So I'm involved in a number of grants in our department, but also with some community partners, including Yale University. So typically, if I was in New York or anywhere else, there might be like 5% of my time written into the grant. In Connecticut, at least in New Haven, we don't do that. So I'm still always, for my salary, 100% on the city side. But now we can use that grant funding to create a brand new position. And then if that grant were to go away, the city's not on the hook for the legacy costs. So different perspectives in terms of how they control the legacy cost. The City of New Haven does it by separating general from special fund. Counties in New York State, control it by keeping the headcount relatively flat. And then when you get grants, that grant offsetting what your general fund positions are already. Because if you say that, when you're doing your budget, if you say, well, I have 300 staff, the county is on the hook for ensuring that all 300 staff are paid for. So they will commit that to the budget. And then if their grant money comes in, then they save money that way. As opposed to with the City of New Haven, you're only on the hook for the general fund employees, but you can add more positions on a special fund. So it's a different environment, and I actually think that the environment in New Haven gives me more flexibility. Well, yes and no. When it's on a special fund, we have contractors, but we also have employees that will work under special fund. They are in a union, and in the last maybe 3 years, the city has been contributing, if you will, to a certain benefit line in terms of matching contributions, where they did not previously do that. Thank you so much.
All right.
Hassan, would you make sure you get that form right there? Hey, thanks for showing up, folks. We have another one next week, right, Hassan? Thank you so much.
Yes, they are. He is. Yes. Yes, yes, she is. Yes, she is.
Are you from Connecticut? I only really